Welcome to Sleep Health with Dr. Alison Bentley. The topic we're going to cover today in this podcast is when should a patient go for a sleep study? I think there's a lot of confusion about what sleep studies do, how we do them, what we're looking for, and it's useful to just itemize that and get some clarity on it. Now, for doctors who might be listening to this podcast, we do have guidelines written by the South African Society for Sleep and Health, which are on our website. That's at sash.org.za. So you're welcome to download that document. It's 25 pages of document reference. So if you're looking for what is the data behind these guidelines, you're welcome to go and look there. You will also find specific forms for requesting these particular sleep studies. So for requesting an apnea study, for requesting a full overnight polysomnogram, if you want to use them. So why do we need to look at why patients should have a sleep study and which patients should we be sending for a sleep study? And the answer is because the sleep studies are expensive. They take a lot of resources. If we're looking at the full overnight study, we have to have a technician on board. So there's a payment for that technician. They are expensive, but we have advanced technology now that can really give us good data from home studies. And so we need to itemize like which patients go for which kind of study. So first of all, I think it's really important to go which patients shouldn't go for sleep studies. Like in which situations are we wasting our time? We're not going to get any relevant data, and let's not spend money on testing that's not worthwhile. So there's no question that if you have patients who have insomnia disorder, so that is insomnia that's chronic, that's going on for a long period of time, there's no evidence of restless legs or periodic limb movement disorder, no evidence of obstructive sleep apnea, no evidence of any biological sleep disorder, and what they need is cognitive behavioral therapy or maybe with some help with sleeping tablets. Those patients do not need an overnight sleep study by definition. And for a number of reasons. Firstly, if they have insomnia and they can't sleep in their own bed with nothing attached to them, it's highly likely that when we bring them into a sleep laboratory, attach a couple of tens of wires to them with tape and all kinds of things and a catheter up their nose, that they're unlikely to sleep at all. So we don't get good sleep and we don't get the data that we want. And so they're not good patients to send into a sleep laboratory. Patients who have restless leg syndrome, that is the urge to move their legs when they're awake, so an urge can't sit still, with no evidence of poor quality sleep, so that once they fall asleep, they sleep well and they wake up in the morning and they feel refreshed. So only restless legs, no evidence of periodic limb movement disorder, do not need to have a sleep study. Treat the restless leg syndrome. It's diagnosed on history. You don't need the sleep study to confirm restless leg syndrome. So rather treat that directly. The third group of patients are those who have a clear circadian rhythm disorder related to melatonin. So that would be delayed sleep phase, advanced sleep phase, jet lag, problems with shift work. Don't need to have a sleep study because you're not going to find anything useful on the sleep study that you cannot get just from history. So in those patients, we're not worried about the sleep stages. We would be concerned about delayed sleep phase if there was associated restless legs, but not just for that particular disorder. So let's rather treat those patients appropriately rather than send them for a sleep study, which is not going to give any additional information that's going to help us with managing those patients. So what are the disorders that we're looking for? Now, a lot of patients particularly, are confused because they kind of go, well, if I go into a sleep laboratory and they stick a whole lot of electrodes on me, bands around my chest, things up my nose, things on my legs, I'm not going to have my normal sleep. So how does that help us find the problem with my sleep? And the answer is that we're not looking at your sleep. We are not looking at how much REM sleep you have, how much deep sleep you have, how much light sleep you have, because that's not really the point of the sleep study. What we're looking for is once you fall asleep, what happens then? What happens when you are asleep that you don't know about? Because most people, when we go to sleep, we have no idea what's happened. That's what we're looking for. We're looking for specific things that are happening once you're asleep. So that's why we don't want patients with insomnia, because they're less likely to give us that sleep. The more hours of sleep that you can get, the better we have for diagnosis. So what kind of patients are we really interested in having in the sleep laboratory? Those would be patients who sleep, often sleep 7 to 8 hours, so the appropriate amount of sleep, wake up extremely tired, as if they have not slept. That is the expression they use. I feel as though I haven't slept at all, but I know I have. So they're waking up tired, indicating that the quality of sleep is very poor. Or patients who sleep full hours, wake up in the morning feeling good, and then still fall asleep during the day. So have excessive sleepiness during the day. Those are the groups that we're looking for. Those are the groups that benefit the best from having a sleep study. The other group of patients who we would want to see in the sleep laboratory are those that have abnormal events that are occurring during the night. So this might be as simple as adults who are having lots of sleepwalking at night, which is inappropriate, adults who are having night terrors, adults who are having nightmares, or any adult that you are concerned about for poor quality of sleep, but not really have any clear diagnosis that you know what to do with them. So those would be the groups of patients that we want to send into the sleep laboratory. Because what we're looking for are very specific disorders. We're looking for obstructive sleep apnea. We're looking for periodic limb movement disorder. We're looking for narcolepsy. We're looking for cyclic alternating pattern, REM behavior disorder, or other specific EEG abnormalities. That's what we're looking for. Importantly, the sleep studies are not overnight EEGs. They are not the same thing at all. So you'd use an overnight EEG for patients who have epilepsy at night, or you're concerned that they have epilepsy at night. It's a different test. So the overnight EEG would look at literally hundreds of EEG possibilities that are occurring during the night. Whereas in the sleep test, we really only have 2 channels of EEG. So there are different tests for different purposes. The sleep test is never for epilepsy. That's the overnight EEG. So just to differentiate the 2 kinds of tests. Now, when we think that we have a patient who might need to have a sleep test, there are then 2 different types of tests that we can ask for. The one is a home test, and that home test is specific for sleep apnea. And that test should be used for any patient where you're kind of going, I think they have sleep apnea. I don't know how bad it is, but that's all we're really looking for, sleep apnea. Obstructive sleep apnea is the most common sleep disorder. In South Africa, the modeling study that was done for every country in the world indicated that in South Africa, for patients between the ages of 39 and 69, and this is the general population, not patients, the general population, the prevalence of moderate to severe sleep apnea is likely to be 23%. So 23% of the population are likely to have apnea. That number then gets higher in patients who have cardiac disease, diabetes, who are obese, who are pregnant. That prevalence just goes up when you add other medical conditions to the situation. So, for example, in resistant hypertension, so those are patients who are on 3 or more medications for hypertension and still there's a problem with managing the high blood pressure. 80 to 100% of patients have sleep apnea. And it's causing the hypertension, and the hypertension is never going to be managed unless the sleep apnea is managed. So we really, in those patients, we're not looking for any other disorder. We're not looking for narcolepsy. We're saying, do they have apnea and how bad is it? That's what we want to know. And for those patients, a home study is recommended. It's done in the patient's home. We only look for apnea. Depending on the equipment that is used, you either only have apnea or you may have some sleep stages. You may have body position as well. Ideally, what we'd like is for that sleep study to be done with the best technical device that we have available. And the data that we want something called the AHI, which is the apnea-hypopnea index, which is how many apneas you have or hypopneas you have per hour of sleep. It would be nice if we knew whether they were obstructive or central. That would be nice from the test. We would like to know the body position because 60% of patients have positional apnea, and it gives us a treatment option if we find that the apnea in the supine position is very high. Gives us a treatment option. We would then like to have snoring, although it's not essential. We're not diagnosing snoring. Snoring is not that important. But then as far as the oxygen levels are concerned, we would like to have mean oxygen saturation. We'd like to have minimum saturation. And then the amount of time, the percentage of the night that the patient maintains their oxygen above 90%. Because what we often find is that there is a comorbidity between obstructive sleep apnea and alveolar hyperventilation, particularly in patients who are overweight. And in the patients with alveolar hyperventilation, the entire saturation baseline is low, and we need to be able to pick that up. But that's all we would really monitor are those kinds of things. Obviously monitor pulse rate because that comes with the oxygen saturation. So the home study is done at home. It does need to be recommended by a doctor. So you do need to have a doctor who is recommending or referring the patient for the home study so that those results can go back to the doctor so the doctor can have a conversation with the patient about what next. Okay. So that's the home study. It's fairly simple, tends to be cheaper, is a lot easier for patients to do, and is recommended in the guidelines, international guidelines, again, both for the American Academy of Sleep Medicine, European Society for Sleep Research, and the Australasian Society for Sleep. So all the big international societies, and certainly the Asian Society, South American Society, they will all recommend home studies if all that you're looking for is moderate to severe apnea. So how do you know that a patient might have moderate to severe apnea? 2 questionnaires that you could use. One is the Stop Bang. That's a very simple questionnaire. Both of these questionnaires are freely available. So the Stop Bang questionnaire asks 8 questions with the letters that are Stop Bang. So firstly, S. The S stands for snoring. Do you snore loudly? The T stands for tiredness. Are you tired during the day? The O stands for observed apneas. Has anybody said that you stop breathing at night? The P stands for high blood pressure. So that is the stop part of it. The Bang then goes for BMI. Is your BMI over 30? And that's a division of weight divided by height. Is the BMI over 30? Are you overweight? The A is for age, over the age of 50. N is neck circumference. In men, it's over 17 inches or 43 centimeters, and in women it's over 41 centimeters, and the G is gender for male. So that's the Stop Bang questionnaire, and what's really easy about the Stop Bang is if you answer 5 out of those 8 as yes, there's an 80% chance you have sleep apnea. So that's a really good, easy questionnaire to use. The Epworth Sleepiness Scale really asks how sleepy you are during the day, and that gives us an indication of whether the sleep apnea is really impacting your sleep and what the consequences of that are. So it's freely available. It really asks question, how likely are you to doze off or fall asleep in the following situations? And is really the most validated questionnaire we have looking at sleep generally, as in over the last month or the last week, not the how sleepy are you right now, which is influenced by many, many different factors. So a good questionnaire to use, it has a total score of 24. If you score 10 out of 24, you are significantly sleepy and there is something wrong. So at over 10 over 24 would go, we need to look at what's going on with your sleep. There's something wrong. So those are 2 questionnaires that we would recommend. The Stop Bang, there's also a Berlin questionnaire, which looks for snoring and sleep apnea. That is also validated. So either of those questionnaires can give you a good idea as to whether you should be sending this patient for a sleep study, or whether you should ask your doctor to send you for a sleep study. So, home studies. Now, 2 consequences come from that home study. The one consequence comes and says, yes, you do have moderate severe sleep apnea. We need to treat that. And the recommended treatment would be to go for CPAP. I'm not going to spend a lot of time talking about CPAP. I'm going to do 3 or 4 episodes on CPAP itself as to why that's so. Recommended CPAP. The other option that might come back is that there's no apnea or there's mild apnea. And then that would be a different treatment options for the mild apnea that you would then go for. If it's negative, however, and there's significant sleepiness during the day, which is why it's important to measure the sleepiness during the day, if there's significant sleepiness, then that group of patients need to go and have a full study because there is a problem, it's just not apnea. All that this home study will do is say, is it apnea or not? And if it's not, goes back to the doctor. Doctor goes, I don't care if it's not apnea. There's still something wrong. That's when we would send patients for a full overnight study. Now, the comparison between the full overnight study and the home study is a bit like the difference between a standard radiograph or X-ray that you would take and an MRI. You get much more detail from the full overnight study. But as I mentioned, it is expensive and you do have to go into a facility usually to get a really good data collection on that study. So who are the patients who would routinely go for a full overnight study as opposed for a home study? The full overnight study, anybody who has significant sleep pathology, i.e. they're waking up feeling tired in the morning, but they go, no, I don't snore. My bed partner doesn't say I snore at all. Then you go, right, okay, it's probably not sleep apnea. If you're concerned there's narcolepsy, if it's a pediatric patient, so a child, they're much better served by having a full study rather than a home study. None of the home studies are actually validated for children under the age of 12, i.e. you can do it, but we can't tell you if it's correct or not. And that's because the pediatric patient, they have very subtle respiratory events. You need to see the arousals from EEG that are occurring with these subtle respiratory events, whereas adults have big respiratory events and they're very easy to find. So patients who are very sleepy but probably don't have apnea, patients who you think might have narcolepsy, they need to have a full study as well as a multiple sleep latency test the next day. Pediatric patients that you are concerned that they have something else that you don't know, so like a REM behavior disorder. If you're looking for periodic limb movement disorder, you would have to do a full study to see those leg movements. If there's nightmares, if there's night terrors, any of those kind of patients would have a full overnight study. But so would patients who do have moderate to severe apnea, go on to CPAP. The CPAP works extremely well, and remember, you can download data from any CPAP device to see what is happening, how well is the CPAP working. Works extremely well, but the patient still has symptoms. So just because you have sleep apnea doesn't mean you can't have another sleep disorder as well. So patients who, what we call, have a negative CPAP titration, i.e. the titration works as far as we can see, but it's negative because the patient still has symptoms, they will need to go have a sleep study on CPAP. So while they're having the sleep study, they need to be on their CPAP device because there's something else that was hidden by the sleep apnea in the first place, but is now there that we need to be able to see. So a negative CPAP titration, i.e. the CPAP doesn't work as far as resolving the symptoms are concerned. So there's a clear list of groups of patients who will need to come for a full overnight study. And if you look at the form that's on the SASH website, what's called the full polysomnogram form, you will see all of those conditions itemized to request that this is what I'm looking for, I think is going on in this patient. Because that helps the person who is doing the study actually look for and give you the right kind of information. So what information do you get from a full sleep study? You get all the data that you got from the apnea study, because we do always measure for apnea as well as leg movements and EEG changes. But you will get a whole lot more from, just as you would from an MRI as opposed to an X-ray. You get a whole lot more information. So what you should get is sleep stages. Although we don't worry about the sleep stages, it's useful to see that there's absolutely zero REM sleep, for example. That would indicate something. So we want the sleep stages, how much of each stage, how long were they. We want to look at the arousals and what the arousals were from. Were arousals from movement? Were they from respiratory events? Were they from leg movements? Were they spontaneous? We want to know what the arousals are from. We want to know if there's any cyclic alternating pattern. This is a very specific arousal pattern, which, as its name implies, is cyclical. So every 30 seconds, you'd have one of these big arousals. There's an atlas for it. It has specific components. We find it in many sleep disorders associated with leg movements, sleep apnea, etc. But we also find it on its own in patients who have chronic fatigue syndrome. But we're not sure where it comes from, but it does indicate an instability to sleep. And we're not sure what makes the sleep unstable, though. So it's all of that kind of stuff that should occur. What I think is important for doctors, both for the home studies and for the full polysomnograms, that all the data that is derived, and it's 3 or 4 pages of data, is provided to the doctors in case they're looking for something specific. So, for example, you may find that the AHI in a home study is 15 per hour during the night, which would be moderate sleep apnea. But because you've got the data for the supine AHI, so when patients lie on their back, and the supine AHI is actually 30 per hour, and if you look at when they're not lying on their back at actually 7, that gives you a really good idea of how you can treat this patient. Ask for the data, ask for all the data, see if there's a combo of things that are happening at night which may increase things at different times. Be able to see the hypnogram, be able to see the distribution of leg movements during the night. All of that may be important for your patient to know. So the overnight polysomnogram has a huge extra number of data points that it's giving you, but it should be restricted to those patients who need it rather than just every patient with a sleep disorder. Certainly when it comes to Discovery Medical Aid, they will not pay for an overnight polysomnogram if you think the patient only has sleep apnea. They want you to then rather send the patient for a home study. And so that form that is present on the website, the SASH form for the full overnight polysomnogram, is essential for Discovery Medical Aid for them to approve a full overnight polysomnogram. They also would prefer to have a trained doctor who has been trained in sleep medicine to submit that form, so that somebody who knows a little bit more about sleep medicine. So they call them accredited doctors. The accreditation is done on the society website. So you need to become a member of the society, and then there's a members section. There's a 6-part course on obstructive sleep apnea with MCQs that is then assessed, and if you score over 70% on the MCQs, you become accredited. We send your name to Discovery, and then Discovery allows you to submit for a full overnight polysomnogram. This restriction applies mainly to GPs, and most of the specialties can submit directly for a full overnight polysomnogram. So if you're interested in that course, that is there for you. So those are the 2 types of tests. That's the kind of information that would come from tests. And those are the kinds of patients that we would send for tests. Again, really important to exclude those patients where the test is likely to be negative, in that it's going to be an awake test, so patients with insomnia. When you do send a patient for a sleep test, if they're on medication, it's important to assess that medication as to whether that medication is going to change what we find. Given that what we're looking for is leg movements, so patients who are on any medication that would treat leg movements, such as gabapentin, pregabalin, Pexola, anything like that that's going to actually treat the leg movements, they should come off for the study. But medications like sleeping tablets, antidepressants, none of those are going to change what we pick up on the sleep study. And particularly if you have patients on hypnotics who are coming for a sleep study, they should bring their hypnotics with them because they need to take them. Otherwise, they're not going to sleep. So we want the sleep. We just don't want medications that are going to interfere with either the measurement of leg movements, sleep apnea, or EEG abnormalities, if that's what we're looking for. So we would rather have those medications withdrawn. If you're uncertain, please contact the sleep lab and ask them if these medications are okay for you to take. What's not helpful, as I mentioned, is if you suddenly withdraw medications on the night that you come in for a sleep test, and then we get 2 hours of sleep and we can't see what we're looking for in those 2 hours. So again, please find a company that can do, or a doctor or a neurophysiologist that can do the home studies for you, and learn about the full polysomnogram so that we're sending the right patients for the right tests, and so that you understand the information that comes back and what to do with that information.
You've been listening to another production from Solid Gold Podcasts.